Hello, everyone. Welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm the proud preemie parent and former journalist, and I'm your host from Halifax, Nova Scotia. I'm so honored to have you join us here today. Preemie Chats is brought to you by Canadian Premature Babies Foundation, also known as CPBF. It's a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. Whether you're a parent, a healthcare professional, researcher, or someone interested in understanding more about preterm birth, you're in the right place. Together, we're building a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. Be sure to visit our website, canadianpreemies.org, where you will find helpful resources, our latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live, I'd invite you to join the conversation. I'm so glad you've joined us here today. We want you to share your questions and comments in the chat, and we'll get to them during today's program. If you're watching a recorded session, you can still connect with us through our website there on the screen. It is through meaningful discussions like the one we are about to have where we advance, practice, and grow together. So please let us know where you're watching from. It's always interesting to see where our audience is tuning in from. And we love to hear from you and also share your experience, because this is a place where if we can all share our personal journeys, then we will grow together, learn together. I'm really excited about today's topic because recently I was chatting with a friend who had a late preterm infant, and her child, who's now school-aged, is experiencing some challenges with school. And I think as preemie parents, we're always left wondering, is this because my baby was born early? Late preterm infants are often thought of as more stable than extremely preterm babies, and because of that, things can sometimes go unaddressed. Late preterm babies are at risk for unique neurodevelopmental challenges that can have long-term implications. So, how can trauma-informed neurodevelopmental care principles be applied to support the unique needs of late preterm infants? Today, we're going to learn practical strategies to minimize stress, enhance parent-infant bonding, and promote optimal neurodevelopmental outcomes in this vulnerable population. Leading the charge on this one today is Master's Prepared Clinical Nurse Educator Chantel Morin. She is a trauma-informed certified professional and has completed a course in compassionate activism. Chantel holds certification from the National Association of Neonatal Nurses as a developmental care specialist and has an advanced practice certificate in neonatal nursing. So pleased to have her join us here today. Thank you for coming to share your expertise with us.
Oh, it's absolutely my pleasure.
Oh, I can't hear you, Chantel.
Oh, now?
Still can't.
Okay, hold on. Are we good now?
Nope. Maybe try exiting and coming back in, because we were connecting just a few minutes ago and we could hear each other. So sorry, we're having a technical glitch, but in the meantime, please continue to let us know where you're watching from. I see we have Susie joining us from Hebden Bridge. Oh, Andrea says that they can hear you, Chantel. So maybe it's on my end.
Oh, can you hear me now? Okay.
I can't hear you.
Weird.
Can our audience hear?
Can the audience hear me?
Oh, try again there.
Yes. Now can you hear me? No.
Okay, well, I'll get you to carry on with your presentation.
Okay.
I'll
We'll
put
work
it up here and you go ahead.
Okay, Andrea and Susie are good, so we're good. Perfect. All right, well, thank you, Leah, for everything. I know you can't hear me, but we'll figure that out. Thank you, everybody, so much for joining us today. Welcome, everybody. Again, as Leah lovely introduced me, my name is Chantel Morin, and I'm very passionate about today's topic of trauma-informed developmental care, especially for late preterm infants. Today, this presentation will explore unique neurodevelopmental needs of this often overlooked population and how trauma-informed principles can enhance their outcomes. We're going to dive into the science, some practical strategies, and why every interaction in the NICU matters. I'm glad that you can all hear me. Perfect. Thank you. Leah was going to move my slides, so just bear with me that the slides might be a little delayed moving along just as I flip them back and forth. Oh, Leah, you can hear me now. Perfect. Wonderful. Okay, so just a little disclosure as we get started. The content of today is copyrighted and protected by Canadian intellectual property laws. So we do ask that this is not shared or screenshotted or photos taken for any reason. And my disclaimer is that today the views presented here are that of my own and my work as an associate and trainer with developmental care out of Montreal and not any other professional roles that I hold. So it's just some objectives for us as we go through today is that by the end of today, I hope everyone has a deeper understanding of the neurodevelopmental challenges faced by late preterm infants. We're going to discuss the science of brain development and explore some actionable strategies that align with trauma-informed care principles. These are practices that you can implement immediately to make meaningful difference in your NICU. All right, so let's set the stage here. NICU hospitalization is now recognized as an adverse childhood event or an ACE. When we talk about adverse childhood events, it means it can have a lasting impact on that child's development. Research is showing that stress and trauma during these critical early periods affect brain growth and future outcomes. This is why every interaction we have with these infants matters. It's an opportunity to support their neurodevelopment in a positive way. So I'm going to share with you a tale of two babies right now. Okay, so I'm going to introduce you to baby A, which is the older photo. Baby A was born at 27 weeks in gestation. In the era baby A was born, trauma-informed care as we know it didn't exist. Developmental care wasn't a word that was even used either. Neonatal care was very much in its early stages as well. And many practices we now take for granted hadn't even been developed when baby A was born. For example, surfactant, oxygen titration, fortification of milk, just to name a few. Now we're going to go over and meet baby B, who was born at 34 weeks gestation in a much more modern day NICU. Despite being born in an era of advanced neonatal care, late preterm infants like baby B often get overlooked, as Leah mentioned in the introduction, because they seem stable, they seem healthy. This assumption can lead to care practices that might not fully address their developmental needs. So as we go through the rest of today's talk, I'm going to ask you to think about in the back of your mind, which baby out of baby A and baby B do you think faced greater challenges long term? Think about how early care practices might have influenced their outcomes, and we're going to keep that in mind as we explore their next slides. So first, let's just talk about some common myths about these late preterm babies. Number one, they're just small, full-term babies. That's all. They're fine, right? Number two, they don't need any specialized care. Number three, if they're healthy at discharge, they're fine the rest of their life. And number four, they don't experience stress or pain like extremely preterm infants. And in some cases that in terms of specialized care, maybe they don't from a medical, or a physiological standpoint. It makes my heart so happy when postpartum units have the education and structure and resources and support to keep many late preterm infants with their moms and with their families, because I truly believe that babies with their families. Oh, I'm sorry, my slide was stuck. There we go. So who are these little ones? So late preterm infants are defined as those born between 34 to 36 weeks completed gestation, and they actually represent the largest group of preterm births, up to 75% in some areas. I live and work out of Ontario, Canada. I know there's people from all over here, so welcome. Just to give you a little context, specifically in Ontario, and I know everyone in the world classifies their levels of NICUs or special care nurseries differently. We have levels 1, A, B, 2, A, B, C, and 3. 3 would be your biggest tertiary center that many other places are used to having lots of those. But in Ontario, level 3 only makes up 9 out of 94 of our special care nurseries and NICUs. But levels 2A and B, where most of the 34-week and up babies go, make up 70% of that care population, that care unit population. And often, funding-wise and resource-wise, 80% of the resources are going to 10% of the levels, leaving the smaller levels with a lack of resource, lack of funding, even though they make up the larger population. Okay. And often, despite, appearing relatively healthy, our late pretermers can face very unique challenges in the beginning days and down the road. So initially, we might see respiratory issues, apnea, hypoxia, jaundice, those feeding challenges, hypoglycemia, thermoregulation, immature immune systems that can lead for an increased risk of sepsis. But it's those longer term things that are often overlooked because they don't appear as visibly vulnerable as those extreme preterm infants. It's the long-term neurodevelopmental outcomes, cognitive delays. Research has shown that they have decreased school age outcomes, increases in ADHD and autism, just to name a few. So let's go a little science-based here and talk about brain development. So that last 6 weeks of brain development while baby's in utero is so rapid. There's so much happening the last 6 weeks. 65% of our brain growth actually happens in those last 6 weeks of development. Like, that is massive. Think about how much is happening right there. It's lots of that brain volume is developed during that time. And so because these babies are born in such a period of phase of rapid synaptogenesis, which is where the white matter and the key sensory pathways are still maturing and making those connections, that idea that neurons fire together, wire together, now we're interrupting it. So this is really important because these infants' brains aren't ready to handle the external stimuli of life outside of the womb, whether this be in postpartum or NICU. We've got light, we've got sound, we have touch, we have gravity. So either the care we give them can really support their development, or it can contribute to stress-induced disruptions and poor outcomes. So this is why that we really need to put that trauma-informed developmental care towards these babies in whatever setting they're in, because it really helps protect that brain architecture during such a vulnerable time. Okay, so I'm going to just touch a little bit deeper into pain and stress on brain development, because this is where a lot of the challenges come from. Unmanaged pain and stress during hospitalization is not just momentary. It leaves a truly lasting imprint on the developing brain. For late preterm infants, that prolonged exposure to stress disrupts that white matter integrity and increases their cortisol level, leading to long-term difficulties in that stress regulation, that fight or flight motion. Every interaction in the NICU is an opportunity to shape a healthy brain. When we integrate our trauma-informed principles, NICU teams or postpartum teams and families can work daily to actively reduce the risks. And we're going to get much more into the practices that you can do, from pain mitigation to environmental stressors and involving families as well. So we're going to go a little more deeper down into the pain and stress and just see how it's actually experienced within our body and within babies. Unfortunately, pain and stress is part of every NICU experience, or even a baby that is on postpartum. But we really need to recognize how it's manifested in our babies. Unlike adults, infants cannot verbalize their pain and stress. They can't say to us, "Stop, that hurts," but they can communicate through very clear observational cues. Babies are really good at talking to us. We just have to learn to listen to them. These cues, again, often go unnoticed or they're misunderstood, which then can lead to underestimating the impact on that developing brain. So we can see the stress and the pain, physical and behavioral changes. It might be crying, grimacing, changes in heart rate or respirations. That physiological response is often an indicator that we've activated the stress response system or that HPA axis. Okay. Behavioral cues are also very critical. That flailing of limbs, arching of the back, that hand comes up with a stop sign. They're reminding us that this pain and stress are real right now to them, and it's not just discomfort or irritability. So while these observational cues are very important, they're really just the tip of the iceberg. Underneath all that pain and stress is activating physiological systems that are leaving lasting imprints on the developing brain right down to that cellular level. And I'm going to explore that a little bit more now in the next slide. So now with that, we've looked at how pain and stress present themselves visibly. We're going to talk about what happens down underneath that surface, that unseen impact that you can't get. When an infant experiences stress, so this could be from being woken up, the way they're touched, the way they're handled, from a painful procedure, anything like that. That hypothalamic pituitary adrenal axis, commonly known as the HPA axis, gets activated. It's going to trigger that neuroendocrine response, releasing cortisol, the body's stress hormone. Well, cortisol is important in all of us to manage acute stress. Chronic or repeated activation of this system leads to an oxidative stress and cytotoxicity, meaning it gets down to the cells and starts to damage the cells. The HPA axis and the sympathetic nervous system are creating a feedback loop, perpetuating that stress response. So instead of resolving stress, that body is now staying in a heightened state, which is toxic to that developing system. So that baby stays in that fight or flight more. And because we've already said there's so much brain growth happening during this very rapid period of development, it's the pain and stress that our late pretermers experience are very... The two parts of the brain that are most vulnerable are the limbic system and the prefrontal cortex. Our limbic system, which includes the amygdala, the hippocampus, is responsible for memory, emotional regulation, and processing experiences. So if we think back to that beginning slide where we said these infants can struggle later on with emotional dysregulation, with ADHD, with autism, with cognitive delay, that makes perfect sense because we're hitting that limbic system, right? Chronic stress is disrupting that normal development, leading to those challenges. The prefrontal cortex, which governs executive functioning, such as decision-making, attention, and higher level cognition, is that other key area really impacted by prolonged stress and inflammation. Okay. Repeated stress responses don't just go away. They become biologically integrated into the body at a cellular level. This means that the infant's brain and nervous system begin to expect stress. It rewires them for survival rather than optimal growth. It's derailing development at a really critical time, and it's going to impact their capacity for self-regulation and learning as they grow. But you know what? It's not all bad news. We can do something about it. Sorry, I'm being a little delayed in my slides. Here we go. So we titled this talk Trauma-Informed Care. So let's get into what trauma-informed care is. So first, we are going to just start at the very beginning with trauma. What is trauma? There are very many different definitions out there. For today, we're going to focus on the one put out by SAMHSA, or the Substance Abuse and Mental Health Administration. They say that individual trauma occurs from an event or a series of events or a set of circumstances that are experienced by an individual as physically or emotionally harmful or life-threatening, and it has lasting adverse effects on the individual's functioning and mental, physical, social emotional or spiritual well-being. I don't know a NICU stay that wouldn't meet all those check marks, right? It's going to be different for everybody. And more recently, the AAP has recognized NICU hospitalization as a trauma. So, to me, trauma-informed care is not a luxury. It's not essential. And when we say trauma-informed care, I know some people don't love the word trauma. We don't like to think that we're traumatizing anybody. And it's really that umbrella that encompasses everything: developmental, neuroprotective care, family integrated care, right? It's just that overarching term that we want to mitigate any harm and try not to do it in the first place where possible. Okay. Trauma-informed care really reduces the risks associated with pain and stress while actively promoting better cognitive, emotional, and sensory outcomes. And then when families are involved, stress is minimized. This is where our babies truly thrive. So thinking as we go through the next slides, I want you to continue to think about your current NICU or postpartum practice and think about how they can align with trauma-informed principles. What small changes make a big difference? So we've talked almost every slide about how it's really essential to use trauma-informed care to reduce the long-term impacts of stress and pain on that developing brain. One key point of trauma-informed care is the intentional modification of the neonate or infant's environment. This means making thoughtful, evidence-based changes that support the infant's growth, well-being, and neurodevelopment. The neonatal environment can be a source of toxic stress if not managed carefully. Constant alarms, bright lights, frequent disruptions can overstimulate an infant's underdeveloped nervous system, contributing to long-term adverse outcomes. Our goal is to minimize these stressors to create calm, supportive environment. We want to promote optimal development and neuroprotection because we know that this is a period of rapid brain growth. How can we help make the conditions how can we create those conditions to promote those healthy, positive neural connections? Neuroprotection means that we're safeguarding that developing brain from harmful external stimuli and influences and ensuring that the babies have the best possible start in life. And then how can we prevent trauma? Trauma isn't about major life events necessarily. It can result from everyday caregiving practices if they aren't aligned with the infant's developmental needs. For example, uncoordinated care. Excessive painful procedures can have lasting impact. We need to present ourselves as being intentional in each care moment that we have, and prevent avoidable trauma and foster resilience instead. And then age-appropriate and family-centered care. These late preterm babies, like we saw in the MISS, are not just smaller versions of full-term babies. They require age-appropriate care tailored to their unique developmental stage. This means involving families every step of the way. Parents are not visitors. They are integral partners in their infant's care and healing processes. So there's multiple levels of care strategies we can look at when we are talking about developmental neuroprotective trauma-informed care. So we have at the organization level, this refers to your policies and your protocols and procedures that guide trauma-informed care across the NICU. It's about setting standards of care, of how care should be delivered, from how staff communicate with families to how procedures are prioritized to minimize stress. We can do our therapeutic measures, which are the hands-on strategies: skin-to-skin contact, cue-based feeding, pain management interventions, and non-nutritive sucking. These are just a few that can directly promote neuroprotection and emotional regulation. And then our environmental measures. What can we do? And I get this is a challenge because we can't just go change the ventilation and change the lights in our physical spaces, but can we turn the lights down? Can we dim them? Can we keep our voices down? Is there a way to reduce noise from equipment and alarms? Not always, I get it. And then can we create individual care spaces that prioritize comfort and calmness, knowing that it's going to be different for every individual? So why does this all matter? Okay. Trauma-informed care is truly essential for mitigating that stress-induced developmental delays and fostering that positive neurodevelopment outcomes in late preterm infants. These infants are in that very critical window of brain development. Every action has the potential to shape their trajectory, positive or negative. So our benefits of using trauma-informed care is it's individualized and supportive, and it aligns with the unique needs of each baby, including promoting that optimal development of neurons. And it reduces toxic stress. We will try to reduce exposures to unnecessary stressors and create that safe environment. And studies are showing that late preterm infants who receive trauma-informed care demonstrate better emotional regulation, sensory processing, and cognitive development. These improvements extend beyond the NICU days and have lasting effects into childhood. But babies aren't there by themselves. They've got their families with them. Trauma-informed care doesn't just benefit the infant, it also strengthens the family's bonds with their babies. When families are involved and empowered as partners in care, they develop a greater sense of confidence and competence, which positively impacts the baby's overall development. So we really want to reinforce that late preterm infants are perceived as less vulnerable than those, 22, 23 weekers, those tiny ones, but they have a very unique neurodevelopmental need because of the time that they're born. Without trauma-informed care practices, these infants are truly at greater risk for developing sensory sensitivities, emotional dysregulation, cognitive impairments that can persist into childhood and beyond. As healthcare providers, if anyone there is joining us today, we have the tools and the knowledge to reduce toxic stress and promote healing for our most vulnerable patients. So keep reflecting as we keep talking about your daily NICU practices. What changes could you make to integrate trauma-informed care principles into your practice? And you might be thinking, but you haven't told me how yet. Now it's time. Let's go look at that. All right. I am a big fan of the lovely Mary Coughlin. If you don't know her work, please Google her and find her. I admit I'm a groupie. She's got my heart. So this model here that we're looking at is directly from Mary's work. At the heart of trauma-informed developmental care are these 5 interconnected measures that create a very holistic approach to supporting the neurodevelopment and emotional well-being of infants and their families. And I'm just going to quickly throw in, I'm talking about late preterm babies, but this applies to full-term hospitalized infants as well. Those babies that are full-term that are sick as well, all of the principles absolutely still apply, okay? The measures here laid out in this framework are measures to ensure that every action, every interaction align with our principles of safety, trust, and empowerment. So let's break it down. At the center of our diagram is kangaroo care. All right. I'm sure we've had lots of talks on kangaroo care and skin to skin care, and I shouldn't have to tell anybody absolutely how amazing it is, but we'll just do one quick little recap. Maybe you're a new student or new to NICU, and that would be amazing too. That kangaroo mother care, skin to skin care really supports physiological stability, emotional regulation, and attachment between the infant and their caregiver. Research consistently highlights the profound impact that kangaroo care has on short and long-term outcomes, including reduced mortality and better brain development. It really is, if that baby can't be in the womb, it's the next perfect environment for them. And then surrounding our measures of kangaroo care, we have our 5 core measures. Each one's really essential on its own, but together they create a really comprehensive care system, and they aren't necessarily in an order. They're not linear. I feel like I could draw lines connecting each and every one of them in that circle because they're really all kind of mushed together. So cue-based care is that responding to the infant's subtle signals to guide your interaction. You can use assessment tools for these. Maybe you use a sleep-wake assessment tool in your NICU or feeding readiness score, something like that. Family involvement is also here, integrating parents as equal partners. I know sometimes as NICU nurses, we have a bad habit of saying, my baby, they're not our babies. I've been guilty of it in the past, absolutely. We are really the cheerleaders and that extra caregiver supporter. Is there medical things we need to partake in to help that baby heal? Absolutely. But it's truly the family at the end of the day that needs to learn this baby and to be able to take them home and care for them. And that they should really be integrated into the environment of care. Pain and stress management is another core measure, so that we know we can't get rid of all pain in the NICU, but how can we mitigate it and minimize it and provide comfort as well during the medical procedures. Feeding practices fall into activities of daily living, and they promote infant-driven feeding that respects the infant's cues and abilities. Positioning as well falls into activities of daily living. So we use evidence-based tools and techniques to support body alignment and comfort. So now we're going to go look at each measure as we move forward and consider how these principles are or could be applied in your daily practice. Tell me, what measures are most familiar to you and maybe what area you might need to more focus on after today. All right. I know we talked a lot about pain and stress, but this is so important. So we're going to dive in just a little bit longer here. So bear with me, okay? Pain and stress are not only distressing for the infant, but they have long-term impacts on their brain development. And those preterm infants who are already vulnerable, it makes trauma-informed care necessary. But also realize that we want to promote that parent integration, but seeing their baby in pain and stress might be upsetting to them. So really, we care for the infant, but how do we care for that whole family as well? Because we didn't go too much into it today because we just don't have time to go into the full part of predictability and buffering with pain and stress. But happy for anyone to message me and we can talk ad nauseum about all of that afterwards. Okay. So our care teams, ourselves as professionals, parents, caregivers, really start at the beginning by recognizing the cues, the change in heart rate, the facial expressions, and the behavioral signs. So if we first can recognize those signs, we can respond early to mitigate any unnecessary stress and reduce the likelihood of that long-term developmental challenges. Talk about, and this is where if we can recognize it, we can teach the parents how to recognize it, and they can be the buffer as well. And then we're going to implement pain management strategies. Could be sucrose, could be skin-to-skin contact, simple but effective interventions. Sorry, excuse me. We want to reduce stress through environmental adjustments that could be clustering our care routines, create a calmer, safer NICU, and bringing parents in on those measures too. I'm so sorry. And then educate parents on how they can work together on those stress-reducing techniques. It not only helps the infant, but it gives that family that empowerment to be very active participants in their baby's care. Again, we're those cheerleaders. We want to educate, we want to promote, we want to advocate for that parental involvement. I don't know anybody that gets pregnant and says, I hope my baby goes to the NICU. It's often a very unexpected event. And for many families that have babies, this is their first hospital experience too. And then to be thrown right into this environment, that causes a lot of stress to those families as well. So what can we do to really integrate them into care and be supportive as well? Okay, we're going to talk a little bit about sleep. Sleep is a very vital healing process, I think, for any of us, not just for our babies. It's particularly important for the late pretermers. Again, that brain is in that massive critical stage of growth. When we're in sleep, or when our little ones are in sleep, the brain consolidates memories, it processes information, and it builds those neural pathways, those neurons that fire together, wire together, that are very essential for cognitive emotional development. Interruptions in sleep, whether from unnecessary procedures, noise, lights, can disrupt that process, and it leaves those lasting effects. So what can we do about it is we can cluster our care to care activities to minimize those disruptions, use those environmental adjustments like dimming lights, reducing noise, and we can implement such tools as sleep-wake assessment so that we aren't at least waking, if we do have a care that has to happen, that we're not waking babies in that really deep sleep mode to get that good growth period. We'll talk a little bit now about activities of daily living. This is where a lot of cue-based care comes in. Every interaction with an infant during daily care, whether it's feeding, diaper changing, or bathing, has the potential to either calm them or overstimulate them. We could talk probably many, many hours just on these things about diaper changing, feeding, and bathing. We don't have time for all that today, but examples that you can change in your practice potentially, swaddle bathing. I love swaddle bathing. If you're not sure what it is, how to do it, YouTube, great resource. And we want to use our cue-based care strategy. So that really focuses on observing and respecting the infant signals, allowing them to lead at their pace, right? They're talking to us. We got to listen. We wouldn't just walk into a room of an adult patient or even a pediatric patient, turn on the lights, strip off their blankets, and start doing stuff to them, because we probably get yelled at and hit a little bit. We would not be loved that day. And I think there's been this long-term stigma or mentality that babies remember this, it doesn't impact them, it doesn't matter. But we know it does. The research has been there for a while now that, these tiny humans, it matters, and we need to show them the same respect in their care as we would anybody else of any age. Some examples of cues that you might see, the infant might turn their head away, they might show signs of distress. Give them a pause, and I'm not talking like hours, to 10, let them recover, count to 30. You'll see, if they're really flailing, bring them back into that fetal position, give them a minute to be calm. Using that gentle and mindful care not only builds trust with them, but it also reduces stress. It's going to help support their self-regulation and long-term development down the road. We know feeding can be often a challenge for this population, very much. And what I want to ask you is, are we doing it to them, or are we doing it with them? Infant-driven feeding techniques, where the baby leads the feeding process, help reduce stress and promote successful feeding experiences. We want to avoid pressuring them to complete a feed, and we always want to monitor for signs of stress, such as changes in breathing, disengagement, hand up as a stop sign. And I know this is a big undertaking, and it takes a long time to change this practice from the idea of quantity-driven feeding, or volume-driven, to the quality and helping these little ones develop skill. I was really shocked in the last couple of years as I've been diving into this journey to learn about the amount of NICU babies that, because we don't get that follow-up, right, that come back down the road 4 months, 6 months, 8 months with oral aversion, with feeding challenges. And then you'll often have to wonder, like, what's happening there? Is it because we did it to them in the NICU, or did we do it with them? So that's really something to think about. We'll talk a little bit of that healing environment. We've already touched on noise and lights, but this also is trying to create that atmosphere that can mimic mommy's belly, right, or that womb, to really promote that regulation and stress. So this is probably one of the most challenging things to do, because there's no gravity in the womb. We've got a 360-degree waterbed bubble. And this is not part of today's talk. I challenge anyone that really wants to know more to dive into the amazing Dr. All's synaptive theory, because that will really help you understand that, if babies aren't physiologically stable, they can't be expected to then be stable in their motor and then keep growing out there. So, a baby that's struggling to breathe isn't going to be able to put themselves in that fetal position. So we need to help them do that while they can't. So we can use developmental positioning tools. You might have tools that you love. You can do it all with blankets too, and what you got around. Really, at the end of the day, I always tell people, I don't care what you use. Does the baby look like a fetus? Until they can do it on their own, until they can maintain that flexion. You can use swaddling or soft supports to promote that comfort and encourage that healthy physical and neurodevelopmental outcomes. A healing environment isn't really just about what we do. It's about creating a space where infants and families also feel supported. One more thing I'd love to mention about positioning is that, especially the younger our babies are and the smaller they are in utero, they've got a lot more room to stretch out. So they've got really, really great extensor muscles. And when they're born early, we really need to help promote those flexor muscles, because if we don't help promote this central flexion early on, this is where down the road, again, the things we don't get to see as NICU caregivers often is that if we haven't promoted flexion, these are skills that they need later on to crawl, to put hand to mouth motions. If we've got our babies always in these big W arms, or splayed out, they're not going to be able to have those motions later on. And it's about facilitating this. We also, at the same time, don't need to be mummifying babies. They shouldn't be wrapped so tight that they can't move. It's about creating gentle barriers that if they do reach out, because again, they're allowed to move and reach out, but there's a boundary there that they can come back into flexion afterwards. All right, compassionate, collaborative relationships truly, I believe, lie at the heart of trauma-informed care. Again, nobody thinks, I hope my baby ends up in a NICU. It's a completely unexpected path and journey for so many families. We've talked about this before. I'll say it till I'm blue in the face. Parents are not visitors. They are essential partners. They should be included in all daily caregiving routines, such as cue-based feeding, kangaroo care, rounds. Okay. For them, it will really build their confidence and strengthen their infant bonds. Equally important, though, is fostering collaboration in your NICU team. When caregivers feel valued and supported, they're better equipped to extend that compassion out to families. It's a culture of trust and teamwork that leads to better outcomes for everybody involved. And back at the heartbeat of it all was our kangaroo care. Okay. It was truly that one of the most powerful tools we have for supporting neurodevelopment and emotional well-being of not just our late preterm infants, any infant. Skin-to-skin contact, we know, stabilizes vital signs. It reduces stress and promotes a sense of security. It's simple and yet so transformative that it strengthens that infant bond. It's empower families to play an active role in their baby's growth and recovery. They can be the medicine. How amazing is that? Studies consistently show how much it enhances long-term neurodevelopmental outcomes. It truly is the cornerstone of trauma-informed care. One thing I do want to mention, sometimes I've heard but the baby didn't like skin to skin. Tell me more, and I think we have to look, what was the state the baby was in before we put it to skin? And how did we get it into skin to skin? Did we already do 1,000 procedures and diaper change and bath before we put it skin to skin? And it's just like, oh my God, this was too much for me. Did we pick it up and fly it across the room? I don't have a doll with me to show you, but they're on their back, their limbs are flailed out, and then we gave it to mom. Or, did we do a standing transfer, which is the optimal thing? Keep that baby in that fetal position the whole time, let mom lean down, pick it up and get them set. You'll find a much, much more stable, calmer baby when we're moving into skin-to-skin care. So let's do just a little case study here. I've got on the screen some late preterm babies. And let's just see what we're looking at here. So baby, it's on my left. I don't know if it's your left or not. The one with the raised arm. What are we seeing here? What do you see? If you want to throw it in the chat, you can. I know, or you can't have that same conversation. But that arm's up, that stop sign's coming out, their gaze is averted. If you look really closely, they're models. They're showing us signs of stress. So, and yet we're just letting them sit there naked, right? So maybe let's put them skin to skin. Let's get them back into the fetal position. Their legs are up, but they don't look like they have that tone in their upper body yet. That's usually one of the later ones to come out. Our other one with the little blue hat on there, position-wise, the legs could be flexed up a little bit more, but again, modeled, grimaced, being unwrapped. They're like, hey, it's cold out here. Let's get these babies skin to skin and help calm them down. All right, the moment you've been waiting for. We are going back to our tale of two babies, and I'm going to reveal to you the outcomes. Dun, dun, dun. If you hadn't guessed it. So I am going to let you know here, baby A is me. I was born at 27 weeks in 1980. And again, a time of no surfactant, clearly no developmental positioning, no fortifier, no oxygen adjustments. And somehow, I thank my lucky stars every day, I've thrived. I don't know how. I often will look back at this picture. I'm 2 days old there, I think. And I don't get it. I really don't. My mother was very ill. I was separated from her very often for long periods of time. I had great family members around, so there's definitely a lot of love there. but there was a lot of adversity to overcome, and it's fine. Now, baby B there is my son. I actually have 3 late preterm babies. All of my babes are late pretermers, and that is why this population specifically is very near and dear to my heart. So this is my middle son, born at 34 plus 5. In a time where kangaroo care was well known, but I was denied. I was told, no, can't hold him. He's got to rest all day, got to rest. Nope, can't hold him, got to rest. This was when the CPAP was even off too. You would think things would be fine, quick hospital stay, 5 days in the NICU. It was a very noisy, a very loud NICU, very bright, 6 feet away from the next baby. I'm sure many people can resonate with that. And unfortunately, he's had a lot of challenges in his life, and you never know. We didn't get into epigenetics of everything about what's prematurity and genetics and all those things. But he struggled with gross motor delay, fine motor delay, auditory processing disorder, sensory processing disorder, a weakened immune system that made them susceptible to an autoimmune disorder that exacerbated extreme anxiety, OCD, emotional dysregulation. This was a child that was always in that fight or flight response, like just pin drop, like go, blowing off the top, always in that heightened state. We talked about that pain or stress. But, I don't want to make it all sound bad, because look at that handsome boy. He is thriving now. I would say the first 13 years was a struggle. There was a lot of therapy, a lot of supports to get him to where he is today. He's a successful honor roll student. He's got a clear path in his life. He's a national lifeguard. He's a swim instructor, and he's just truly come into his own. And I'm a proud mama now, but he is my why that I just spent this last bit of time with you, about why we never know the long-term outcomes or what is going to necessarily make or break a family or a baby. What we do every day in our practice truly has a very lasting impact. And I think we owe it to our little ones. I think it's easy in healthcare to get lost in the check boxes and tasks. And if we can just take a step back, take a breath, and remember, why are we here and why are we doing this? I hope this story helps resonate with you and find your why again. So I'm going to leave you with one question. What is one change you are going to implement today? Every interaction in the NICU or with a late preterm family, even on a postpartum unit, it truly matters. Those small intentional actions that we take every day truly shape the neurodevelopmental trajectory of these babies. By approaching care through a trauma-informed lens, we can assure that every interaction contributes positively to the baby's long-term well-being. So as we conclude, I hope you'll take some time and reflect on your practices and figure out, if you're working now, the next time you get up, what little change can you make? Maybe it's just standing at the bedside and introducing that you were there. I know it sounds silly because they don't understand our language, but they'll still hear that we're there, right? Hey, Emma, it's time to eat. Count to 10. Lay a hand on Emma. Count to 10 again. Give her a chance. Again, no just flipping and stripping. Like, we're just going to send that HPA access off in a frenzy. Okay? But also remember, trauma-informed care is a journey. There is not a finish line. It is not a race. And every step makes a difference. So thank you so much. And there's references here if you're looking for more information.
Thank you so much, Chantel. I do have to tell you that I have about an 8-second delay. So this is going to be an interesting question answer time, but I think if we're patient with each other, we can get through it. And so my first question that I first of all wanted to thank you for sharing your personal experience. That is, I know as a preemie parent myself, it is sacred. It is so dear to our hearts. And so when people are willing to share their own experience, it's meaningful and beautiful. So thank you for sharing that with us. Now, you gave us lots of awesome practical things that families could do. And as a parent, I would want to do it all when I'm in NICU and have my checklist. And you gave us also I like that strategy of one thing that healthcare providers could do. But I'm wondering, how can we get this kind of information? Because I'm assuming the education's just not out there for it not to be happening. So what's something practical that units could do to start, and I don't mean individual, but as whole units, that they could do to start implementing something involving neurodevelopmental care?
Oh, that's a big question because every unit is at such different levels of understanding. Like, I think it needs to come as a team approach, very much. Like, it can't just come, then you get into whole change management, which is always a challenge. It needs to be at the care level of each person. Oh, see, I love that you got that OT background. I can also tell you most of all the level 2s in Ontario have 0 OT, no therapy. So it's got to come from the frontline nurses as well. And we often, we have no speech, we have no therapy. They're just reserved for that 9%. I think if we could go one thing, skin to skin, take it back to that core, take it back to that center. Within Canada, we have the Canadian Paediatric Society's newly released guidelines that really, support it. Maybe it's posters on the wall for everybody as reminders, because I think if parents are more aware, then it challenges us as healthcare professionals to be like, if they're the advocate, and as well saying, this is important to me, this is what I want to do. But you really need that buy-in then from the front line to management to directors, like that organizational, to say, like, this is what we're doing here. Like, this is the approach we're taking, and this is where we're going to start. Knowing that some things to change are much more challenging than others. Like, I worked in NICUs with very loud ventilation, and that's not in my control. But promoting skin to skin is. But then it's like, what does your room look like? Do you have single rooms? Do you have an open bay room? What do you have to have chairs? Like, it's so complex. Does that answer your question a little bit?
Thank you. We have this other question from Susie saying, is it possible to get the reading list?
Does she mean references? I would think so. Happy to share.
I think we have lots of comments in the chat from people who are interested. I love this. I just want to highlight, I would like to see quality feeds, not quantity feeds.
Yes.
I loved what you said. Are we doing this to or with? I think those kind of things are so important for all of us to keep in mind, healthcare staff and for families. And so I'm just going to ask you one more question because of this technical difficulty, and I apologize because this has been so good. Oh, Susie clarified for us that she's talking about references.
Yes. How do we usually facilitate getting things to people?
I can pop that up here. Okay. And so the
Susie,
best thing about these lives is you can go back and rewatch them as well. So we'll encourage people to go back and rewatch. I'll leave this slide up for a few minutes. Okay, sorry to talk over you, Chantel. This is driving me crazy with the 8 seconds. But the final question I want to ask you is a personal question, because you did show your son and you shared some of the challenges that he experienced after NICU. And then you shared how well he is doing now. And I think one thing that this community does, this Canadian Premature Babies Foundation community, is we create hope for other families. And so I'm just wondering if you could give a piece of advice to those families who are outside of NICU, who are experiencing these kind of challenges with their kids who were late preterm. What kind of advice would you leave them with today?
Don't stop advocating. I was a big mama bear for him. I pushed and pushed and got him everything he needs. I think what's sad sometimes is I know not everyone's in the place that fortunately our family was in, that because he never met that magic checkbox of formal diagnoses like autism, right? There was no resources available, no funding to help us. Everything was out of pocket, but we were in the place that we could do that for him. And, if somebody said, try this, I'm like, okay, let's do it. We tried probably 3 or 4 types of therapy till we found the one that worked better. Diet, environment, all the things as a baby you do too, to really get him through. And just know you're not alone. It can be a very lonely path when you are dealing, especially with invisible challenges, because that's what he was. To look at him, other than being tiny like his mama, you wouldn't know anything that was going on underneath the surface and underneath the skin until you really dive down, and then you started realizing, oh yeah, but again, I think that goes to that larger piece of, it's a gigantic healthcare thing that it should be in health histories. Were you premature or not, right? And recognizing that it is a phenotype, and it is got long-lasting effects. Even myself as an adult preemie, touch wood, right now I'm okay, but I'm knowing that there's more and more research coming out that I still need to be careful that I'm at risk for kidneys issues or cardiovascular issues down the road, that, those things matter. And I don't think healthcare providers know that. Do I wish I could just scream it all to the world at the top of my lungs and get that message out that, hey, this matters? And I think just knowing that, be intentional in everything that we do, and knowing that we can make a difference. What we do now can truly change the trajectory of someone's life.
Thank you so much. And I love what you said about, sometimes it's that simple question that our healthcare providers could be asking: were you born premature? And that can highlight better care for people. I want to thank you so much for joining us here today, for sticking it out with me through the technical difficulties, but for sharing your wisdom and truly making a difference in NICUs, not only across Canada, but internationally. We know we have many people who watch this. And so I appreciate you sharing your wisdom and hope with our listening audience today.
My pleasure. Thank you so much for having me.
And thank you, everyone, for joining us for today's episode of Preemie Chats. If you did miss part of today's episode, or if you want to revisit it, I know people were asking about the references, then you can find this episode and all past episodes on Canadian Premature Babies Foundation YouTube channel, or on our website. Again, that is CanadianPreemies.org. And while you're there, explore the many resources and support options we offer to help families on their journey. As a charitable organization, CPBF relies on the generous support of people like you. Your donations allow us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. Thank you for being a part of this very special community. We'll see you next Friday at 1 p.m. Eastern Time for another live episode of Preemie Chats. Have a good week.